And today we're going to be breaking down ACL injuries, how they happen, who's at risk, and what recovery looks like. We'll also cover prevention tips and the key role physical therapy plays in getting you back to peak performance. Let's dive in. Welcome to the Pitchside Performance Podcast. I'm Dr. Zack, Atwood, a performance physical therapist, and alongside me is Elisa, Baeron, a sports performance coach from Michigan State University. We are both former college soccer players passionate about helping athletes, coaches, and clinicians improve their rehab and performance. On this podcast, we'll dive into soccer-specific injuries, cutting-edge rehab techniques, and elite performance training tips. Plus, we'll bring on experts from the field of sports medicine, strength and conditioning, and nutrition, along with guest interviews from former players sharing their recovery and performance insights. Let's get you stronger, faster, and back on the field. Welcome, everybody. Welcome, Elisa. I'm super excited to get this podcast rolling. I know this is something we've been talking about for a very long time throughout the rehab journey, and I'm so glad to get together and actually start doing this.
Yeah, no, I'm super hyped for this. I think it's the stuff that we shared and we talked about. I think it's so important to share with other people too, and let them be part of this process of coming back from an injury and how can we be better athletes, how can we be better coaches and practitioners. So I'm super hyped to hopefully make a difference.
Yes. That is the key. Well, let's get into it.
All right. Zack, what is the ACL and what is the role of the ACL in the knee?
It's a great question. It's loaded.
So keep it simple.
Yes. So the ACL, the anterior cruciate ligament, is the main stabilizer of the knee. So basically, the ligament itself reduces shear forces going forward in the knee, as well as rotation that happens in the knee. Things like pivoting sports, where it's going to be the most demanding just from how much cutting is involved, change of direction is involved. It just puts that at a higher risk of injury. So there's a lot of things that, it's a very common injury as far as we see in soccer and other field sports as well, unfortunately.
With that, who sustains the ACL injury, and are there any specific type of athletes or sports or positions that sustain ACL injuries more often than others?
Yeah, so as far as what we classify as like type 1 sports, which are pretty much like the sports that are like the highest involved with pivoting and cutting. So like your soccer, your football, your lacrosse, things like, or basketball as well, where you're going to have a lot of those change of directions. That's those what we would classify as type 1 sports, and so those people are going to be at a higher risk. To get more specific though, soccer is definitely one of the higher sports to have athletes suffer this type of injury, and there's a lot of thinking or thoughts of why. And I know people get into field surfaces, whether it's grass, turf. Females are definitely more at a higher risk than the males. And again, there's a lot of reasoning as to potentially why that is, whether it's, hormonal, whether it is strength, whether it is just body type compared to males. There's no definitive answer, but there's just a lot of theories as to why. As far as age groups, usually you're looking at that 14 years old to 18-year-old being the highest risk of injury. And again, when we look at it, they're going through, maybe they just finished puberty, they're going through puberty, a lot of changes, the body hasn't caught up to them. And unfortunately, we also live in a world where not everybody has access to certain resources. So from a strength and conditioning perspective, some kids just never have trained before and they just play soccer. And unfortunately, the more and more you do that, that just can, it's more exposures. Whereas if we can start to implement some of this strength and conditioning in addition to their training, there's definitely been tons of research to show that it reduces your risk of an injury. So
I think not only the strength condition, but also exposing them to different sports.
Yes.
To allow them to have the body exposed to different type of moves and not just one, I think can also be a big factor.
100%.
that as well.
And I think that brings up a really good point, because just nowadays it's like so many kids are specializing at such a young age that they're not getting that diversification. And so that's where, I mean, again, when we look at like a graph of, like when you literally look at the graph of ACL injuries, it's almost parabolic, just because when you look at the past few years, seasons are longer, people are specializing at a younger age. And so it's like, again, that's just going to expose that individual to more of a risk. They don't get the rest that they need. They don't get the time off. They're not playing other sports. You have an athlete that's playing at a high level for youth right now. They're playing 11 months out of the year. They're taking a month off. A lot of them aren't taking the month off. They're taking that month to then train to get prepared for the next season. So really there's no break from it. And that's, again, that's challenging, because it's that age gap, or the age group where, again, they're just at a higher risk.
I think too, like I see it more and more, the travel, like where they fly across the country to play multiple games in a weekend, flying back, going right back to training at different surfaces.
Yeah.
And with that too, you know, the recovery aspect, I think, as you mentioned, is going to be tremendous. That is also oftentimes overlooked. It's like nutrition, the sleep, the hydration, the actual taking mentally and physically time off and away from the field or from whatever sport we're playing too, that can all just accumulate to then an injury.
Yeah. Yes.
So with that, how does an ACL actually happen? We mentioned a couple of factors that play a role in it.
Yeah.
But what's the actual mechanism of an ACL injury?
Yeah, so I would say the biggest, or the most common one is, well, first of all, majority of them are non-contact injuries. That's one thing that I will want to make note of, is that it's not always from somebody just coming in and hitting you in your knee. It's actually, majority of them are non-contact.
And the hitting in the knee is considered contact.
Correct. And so the mechanism is usually when somebody plants their foot, they turn, they pivot, and their knee's going one way, their body's going another way. Another way is when somebody's landing from, maybe they just jumped up, they're landing, again, their body is going opposite of what their knee is, so you get that valgus knee where the knee caves in. And then another one is just a hyperextension moment where your knee actually kind of gets stuck, and then it goes backwards to where it pushes back. And there's so many mechanisms that I would say that's the main, few there that you will commonly see. Step pivot, landing from a fall, or the knee just kind of snaps back, buckles back to where it's going into that hyperextension.
So in sports like soccer, we see the dog going up for a header, where maybe someone comes in with a contact and you have an uncontrolled landing. You have an upper body contact. It's on how hard at my first one, upper body contact, cutting in front of someone, the knee gives in, or you just kind of reach for a ball, pivoting as you're planting. When actually does an ACL happen? I think it's a very interesting and also fun fact question. When is actually the ACL tearing?
Well, it only takes less than 1/10 of a second. So less than 100 milliseconds from when your foot hits the ground to where the ACL actually tears, which is extremely fast.
Yeah.
Which is why there are so many great researchers out there right now that are really looking at the brain and how that is a huge factor into your processing of just everything, your ability to, because again, like when your foot hits the ground, like yes, you have to have strength, stability, but also your nervous system has to be primed and ready to take that. And if it's not, if it's delayed, if the visual processing of the information coming in and how you react is not as efficient, puts you at a higher risk.
Yeah.
So there's a lot, and that's a whole nother episode we can go into, is all that stuff, but it is super fascinating when you dive into that stuff and realizing how your rehab actually needs to be tailored into improving that. Because a lot of times people don't get exposed to that stuff throughout the rehab process. Then when they get to the field, like they're sluggish, they don't feel like they're up to speed. The speed of play is slow. Right, because now they're having to take in so much more information than they did when they were just in the clinic, just doing their regular exercises.
And 9+ months, that's a long time to be away from a fast stimulus.
Yes.
Now, besides the ACL, we have plenty of other ligaments, the PCL, the MCL, the ACL, we also have a menisci in our knee. A lot of times, we see an ACL injury also combined with other injuries.
Yeah.
What are other common injuries that are also happening as we tear our ACL?
Yeah, that's a great question. They call it the terrible triad, which is like a commonly they go together. So your ACL, your MCL, and your medial meniscus. Just from where they attach, the MCL and the medial meniscus kind of blend together, and that's why like when that mechanism happens, those are usually at fault. Also suffering an injury. With that, usually the MCL, they don't really surgically repair that, but then the meniscus itself, they may repair it, they may go and clean it up. It kind of depends on what it looks like, how bad it is, blood supply available. So there's a lot of options there, but those are the three that are typically pretty common that go together.
Which makes sense if you think about the knee valgus that happens with the abduction of the knee, the internal rotation. That's a lot of stress if you have an MCL.
Yeah.
So a lot of times, especially in the pivot and cutting movement, and that affects the rehab.
Big time.
Big time.
Yes.
Wow.
Yes. We can get into the specifics of treating a meniscus versus a meniscus with an ACL versus just a ACL as well.
Very different. I've done that. Very, very different rehab.
Yes.
Now, moving on, ACL, it's torn when you get it fixed. There are various grafts out there, and there's continued research out on different grafts, going from hamstring, semitendinosus, to the patella, to the quad, to artificial grafts. Those are just to mention a few. Can you mention some brief key points about each, obviously the locations that they're coming from, and maybe some strength or weaknesses or developments that we have seen over the past recent years?
Yeah. So yeah, you already listed pretty much all of them that I would say. So you have your patellar tendon, patellar tendon bone. You have your hamstring graft. You have your quad tendon graft, which is starting to become more popular, especially in Michigan. You have a allograft, which is where they take it from another person. And then they have a repair where there's a few types of repairs. There's a traditional repair where they actually depend, and usually this is very age dependent. So usually the younger population, you'll see this more, where the ligament itself is just ripped off of specifically where it attaches to the bone. And so they'll just go in and basically just suture it right back on there. So no donor site, none of that. The Baeron procedure, which is a bridge enhanced ACL repair, is where they are now taking, it's where there's a mid substance tear in the ligament. So it's split in half. They're taking a scaffold, soaking it with blood, plasma, all these things to try to help heal it. And they basically just wrap it around the ACL and have it try to heal on itself. That's becoming more popular as well. The third procedure that I would say is kind of like a hybrid of a repair and a reconstruction, because you're still taking a donor site ligament. There's one surgeon in particular in Michigan that has been doing a lot of these, where they basically leave the stump of the old ACL, and then they're taking the new ligament, and then they're attaching it to it to help try to preserve some of the proprioceptive input to see does that help the recovery. Anecdotally, I've seen great results with that procedure. As far as the hamstring specifically, usually they'll take like the semitendinosus, patellar tendon, again, just right here, middle third, and then your quad tendon above the kneecap. As far as positives and negatives to all of them, the patellar tendon, positive wise, is you're going to have that bone to bone fixation, so it's definitely going to have some good healing there. Pretty much the gold standard still. I don't think that has shifted as far as recommendations, especially for an athlete. Hamstring though, I have seen a lot of those as well. The positives to that one is you're going to have less of quadriceps inhibition. On the flip side though, you'll have some hamstring weakness. Typically tend to get a little bit tighter in the back as well. So extension could be kind of problematic. And then there has been studies that have shown that long-term, the graft laxity tends to be a little bit more compared to like your patellar tendon. Quad tendon, not a ton of long-term data, I would say yet, but the idea is that the ligament itself is much thicker. So the idea is that it's going to be much stronger, more robust. The problems that I have seen though with that specific tendon is the quad gets affected more. Typically takes a lot longer for it to get back. So quad inhibition, much larger with the quad tendon, specifically because they're taking it from the rectus femoris muscle, which is a 2-joint muscle. So you're going to have that muscle is affected big time.
So it's sitting over the knee as well as the hip.
Correct. So that one is definitely more of a challenge. But again, they do come back. It just is, from what I've seen and what others have seen, it takes a little bit longer compared to your hamstrings and your patellar tendon to get the quad back up. Your repairs, I have been fortunate to see all of them, and it's very, very fascinating because they bounce back pretty quick because they don't have to take a donor site for the bare or the just regular repair. And so they get their quad back pretty fast, which is really cool to see. So I've seen some really good results with that. The bare is a little more conservative in initial phases just because of the healing of the 2 attachment sites. Whereas the hybrid approach is also something that I have seen a lot of, and again, really good results so far. I've seen people's quads come back fairly quicker compared to just your traditional reconstruction. So that's just kind of a brief outline of all the ones that I've been fortunate to be able to treat, and just kind of see pick up on some of the things that you notice like that are different between the grafts.
So, and I think we'll dive deeper into grafts and which graft to choose based on maybe different criteria, and how the rehab is going to be different with the different grafts, and short term as well as long term.
Yeah.
Now, talking about recovery, how long is the recovery process for an ACL?
So this is a very good question. So minimum 9 months. So research has shown that if you can get to 9 months, your chance of re-injury goes down by 50%.
Which is significant.
Correct. If you go back before 9 months, your chance of re-injury goes up by 7 times. So if we can get you to 9 months, that is the bare minimum for me. I don't promise this accelerated rehab where you're going to get back in 6 months. It's not the case. Now, I will also say though, 9 is the minimum. That doesn't mean you're ready at 9. And I really, really educate people on this because, especially from a high school kid coming into me, where it's like they were just stripped out of their sport means a lot to them. Telling them, hey, it may take a year, that's something that's tough on them. But just making sure that they know that expectation on day one, and they don't just hear me say that 6 months down the road and then they're like, what the heck? I think that's important. So I'm very transparent with every single patient, just outlining those expectations so that they know, hey, 9 months is minimum, but hey, it may take a year, and that's okay. Like it's not, you're not behind. That is normal, and that is totally okay.
I know we had that conversation quite a few times.
Yeah.
Because it is like you hear an opinion from a surgeon who's like, you run at 3 months, you'll be good at 6 months, at 9 months you'll be get cleared. May not be that way. I think every recovery is very, very individual, where you can have the 2 same ACLs, same grafts happen at the same time, and one may be good after 9 months and one may take a year.
Yep.
And I think that's really important to understand is it is your journey, and everyone is going to be on a different timeline for many different reasons. Other external factors that play a role in it too, and how you heal, any complications you may face.
Yeah.
And I think too, having that minimum of 9 months, think, okay, reducing our risk by 51%, thinking long term, especially when we're looking at these high school athletes who want to go to college or continue to have, a quality life, being able to participate in physical activity in sport without having, long-term knee problems. I think having that education as well is going to be really, really helpful and beneficial for a lot of athletes, and understanding, hey, maybe we take an extra month, but that allows you to continue to play for the rest of your life with this. We're pushing it, but maybe that's going to lead to another, not only an ACL, but could be another injury. We're talking Achilles, hip, ankle.
Yeah.
Because, one joint is slacking and another has to compensate, and it's usually the next weakest link in the chain.
Yeah. And that's a really good point, because I've seen a lot of people who have not recovered fully, and unfortunately, they either suffer another injury, either to the other leg, the same leg, or, like you just said, to another area. Achilles has been a very common one. Something with the hip that starts to act up. It is unfortunate. I think that not rushing is key, and making sure that we do have those milestones in place so that we know in these criteria, and we're not just going off of time. Protocols are good for a general recommendation. Like if you're a new clinician, you've never seen one of these, it'll at least get you on track to understand, okay, these are some things that I definitely need to do, but just know that you need to move beyond that, and you need to make sure that you also don't just follow it to a T, because sometimes it does have stuff in there where it's like you said, it's your own journey. A lot of people are not ready at 12 weeks for running, and unfortunately every single protocol that you'll see will either say 10 or 12 weeks.
Yeah.
And again, the patient thinks that they're behind. And so education is so critical, especially right on day one. Day one, I spend a whole hour just educating them on expectations, what this will look like, and bringing up those things that are maybe touchy subjects of when can I play again? When can I run again? When can I do this again? When can I get rid of the crush? All those things that you have to address so that you set the stage, because that will just help everything moving forward if you set the stage on that first day.
And they're very uncomfortable conversations to have, because I think you go the right way if you're being honest, if you're being transparent, and if you are being very truthful. Like, we all want to hear the nice things, like, oh yeah, well, I'll get you back in 9 months, no problem.
Yeah.
But what if you don't? And that is very, very likely, and I think then you put false hopes on an athlete, and then they get devastated. And we're talking the mental aspect. That can really then add just on top of it to being detrimental to performance and the long-term development.
Yeah.
So I think having that transparency, that brutally honest conversation right away sets a really good standard that both the patient and then the practitioner can be on board with, and both be coherent on the same plan, which then also moving forward, you move them on to sports performance coaches and conditioning consultants back at their school, at their club, at their college. Really helps building that holistic staff around the athlete to help them prepare best for the return.
Yeah, absolutely. Thank you for tuning into the Pitchside Performance Podcast. If you guys found this helpful, please be sure to subscribe, leave us a review, and share it with a friend. Follow me and Elisa on social media for more sports rehab and performance tips. See you next time.